Great. It looks like we have a few more people on. So I think we'll go ahead and get started. Thank you all for joining today to talk about Nurture Oregon. We're so excited to have Dr. Deborah Cohen and Sarah Magnuson here. I'll just introduce them both briefly, but I'm just really excited about the opportunity to learn more about Nurture Oregon because it is just a really innovative model that I think the state of Oregon has done a great job of seeing the value in, and Deb and Sarah are here today to talk to us about that and some of the research that's been conducted. Dr. Cohen is a professor and vice chair of research in the Department of Family Medicine at OHSU, and she's an expert in qualitative and mixed methods research with more than 20 years experience and has spent more than a decade studying primary care practices with a focus on clinician-patient communication, implementation of behavioral health integration into primary care, change and improvement, and health information technology use. She's been a principal investigator on several federal and foundation-funded grants and is currently the principal investigator for the Nurture Oregon evaluation. And Sarah Magnuson is a research associate too at CoMagin Health, and she has over a decade of experience in social science and applied public health research in academic and nonprofit settings. She brings particular strength in research and evaluation project management and experience in both qualitative and quantitative methods. Her current work focuses on the implementation and evaluation of integrated care for pregnant people who use drugs and peer support-based models of care. So thank you both for joining, and I'll turn it over to either Deb or Sarah, whoever wants to take it from here.
Great. I'm just going to set up the screen share. Hang on one second. I really appreciate the introduction. I think it's easier to share. Great. Then I'll get it in presentation mode. Can everyone see the slides okay?
Yes, thank you.
Awesome. Well, thank you so much for inviting us to talk with you all today. There are 5 things that we're going to talk about today. And Sarah, do you want to introduce this?
Sure.
It's got,
So yeah, we're just going to do a brief background and overview of what Nurture Oregon is. Deb's going to talk about the evaluation aims. We'll give a little site progress update of our 5 sites, and then a little brief discussion on what we've learned thus far. But really, we want to take a lot of time for question and discussion at the end.
Yeah. So just as a note, Sarah, I see the notes here. Sorry for this operational thing. And I see that your name is in the notes for the next slide. So my apologies. I have to read a slide ahead in order to see who's going to deliver what. And for the audience, we are going to go back and forth between slides for the presentation. So any apologies in advance for the clunkiness of that. I think you're up now.
I think you're up now.
This is your slide? Okay, so clearly I have no idea how these are labeled, but we'll work this out. I was worried about that a little bit. So just a little bit of background on what led to Nurture Oregon. So in 2015, there was a pilot started in the Portland metro area called Project Nurture. And there were 3 pilot sites in Multnomah County. And behind this work was HealthShare, one of the state's CCOs. And what they wanted to test, and by implementing it, was an innovative model for integrating maternity care, substance use disorder treatment, and social service coordination for women who are pregnant. And the thinking behind this was that they could, by creating an interdisciplinary team who could provide services to people in more or less one place, that they could create a team of professionals who could support each other in caring for patients that sometimes needed a lot of care, and they could create a safe and destigmatized place for women to receive both their mental health, their medical, their MAT care, and ideally continue to receive care after their babies were born, both for themselves and for their child. And what they found from the pilot, which was studied by a number of people, but most notably John McConnell and his team at the Center for Health Systems Effectiveness at OHSU, was that this pilot led to reductions in child maltreatment and placement of children in foster care. And it led to increases in prenatal visits and maternal lengths of stay in the hospital. And the results suggested that this model could improve overall human services sector outcomes. So it was really innovative and impactful.
So this is me, Deb. So what is Nurture Oregon? So we are expanding on what we learned from Project Nurture, and really due to a legislative mandate, Oregon Health Authority's Health Systems Division was tasked with building an expanded model of the original Project Nurture pilot. And essentially, the broad idea is to focus on rural and frontier counties and underserved communities, and highlighting a goal of eliminating child welfare involvement and foster care placement. In addition to focusing on those rural and frontier counties, the expansion pilot is also expanding from a focus on clients with opioid use disorder to address all substance use. We are providing cross-site learning collaboratives and cross-site support, mental health counseling to address trauma, and the opportunity for recovery peers to receive doula certification. And we're doing kind of a pilot within a pilot in a state level collaboration with the Child Welfare Office.
Yeah.
Go to the next slide.
Yeah. So just to clarify what Sarah said, so the state is, the child welfare collaboration is, so the state, i.e. Sarah, just to make sure everyone understands, at CoMagin is the implementation team. They are supporting the dissemination and implementation of Project Nurture, which has now been renamed Nurture Oregon, to 5 counties. And these are the components that are involved. Sorry, ahead, Sarah.
No, it's perfect. That was a perfect segue into who's who.
Yeah.
So CoMagin, we are working with OHA on the implementation of Nurture Oregon. So we're, doing program design and implementation support. We are providing these cross-site learning collaboratives and meetings, developing the materials, and doing a light monitoring and evaluation, really just data monitoring to report back to the legislature. And then OHSU is doing the formal evaluation, which originally was qualitative interviews. You'll hear more about this when Deb talks about the NIH aims, but and then that we have this collaborator of ODHS Child Welfare who are doing the CARA plans of care implementation at the Nurture sites, and CARA is Comprehensive Addiction Recovery Act. And these are kind of the 3 main groups of folks who are working with Nurture Oregon sites. As you can imagine, it gets very confusing of who is who, but we all work together pretty well.
Yeah.
You can go to the next
This is you, Sarah.
So the contractual elements that were part of the site and OHA agreements are really providing this team-based model of care. So it includes clinicians who can provide prenatal support and postpartum care, substance use disorder treatment, including access to medications, peer recovery support specialists, pediatric care for the infant once it's born, case management for the team, mental health counseling, and facilitated support groups. There were optional elements that many sites have included, which is a doula or midwife, and then a home visiting nurse or home visiting nurse team. And additionally, their sites were also expected to develop relationships with local resources, including a transparent relationship with their local DHS office, which is both tied to Nurture and the CARA implementation work. Coordination with hospitals for maternity care and stays, really for the birth itself. and supported access to social services and connection to those services. Other implementation elements were community outreach and development of referral pathways into Nurture Oregon, participation in the learning collaboratives and cross-site meetings that we host, and then individual site meetings. And then the expectation of the data collection for monitoring and reporting purposes. And then a commitment to, have the discussion around sustainability planning. So things that we as CoMagin and OHA are doing ongoing for implementation support are these facilitated weekly or bi-weekly working meetings with each team. And really initially this was heavier on the weekly, and now we're kind of tapering down to less often. But this was really how we develop who is doing what within the team. So really defining roles, workflows, program development, and discussing a lot of challenges and how we can maybe overcome them. We're creating documents, including a program manual, integration and workflow guidance, a overall Nurture Oregon intake form, one-pager, much more. We're bridging communication across the teams. We do this both through our cross-site meetings, as well as we have an online portal called Basecamp that's really a document repository and message board. And then we host the online learning collaboratives with developed topic lists that really come directly from the sites around what they would like to get support on. We developed and implemented the database and data monitoring plan, and then we are facilitating the connection and implementation of the plan of care with ODHS Child Welfare.
Yeah.
And then I can just run through the sites, and then the where are we now is on you, Deb. But so again, we focused on rural and frontier counties. So we have 4 rural counties and 1 frontier. Of the funded sites, 1 is based in primary care and 3 are behavioral health, and then 1 is a local health department. So in Umatilla, the funded site is Oregon-Washington Health Network, which is behavioral health. Malheur is the Malheur County Health Department, which is obviously a health department. Jackson is our primary care site as Oasis of the Rogue Valley. And Deschutes is Best Care Treatment Services, which is behavioral health. And Lincoln is Reconnections Counseling, also behavioral health.
Yeah. So I want to just underscore something that Sarah alluded to, which is having been involved in a lot of practice transformation and dissemination and implementation work, this is an enormous undertaking for these sites. And the implementation support that they need is like black belt level coaching, right, to make this work. And it's a multi-year process. And we already have some findings that point to that, because one of the sites has been at this a bit longer than the other, and you can see that it's taken them 2 years to actually build the collaborative team where there's trust and interdisciplinary care. And I can just say from my experience in studying integrated care teams in other places, this is one of the most complicated changes an organization will ever undertake. It requires trust building and relationship building that really is at the core of this work and part of what we're paying attention to. So kudos to CoMagin for signing up for this, frankly. And the child health plan of care only complexifies things, right? Because that is a whole other area of change beyond what Project Nurture did, essentially. So there's a lot to be done to be successful. But that's not my problem, fortunately. So I get to watch. So yeah, it's actually a fun position to be in. I don't mean to poke fun at CoMagin. I think you guys are doing a great job. But it's a lot to do to support these sites. So what's happening at this point? So as we stated, the promising outcomes from Project Nurture prompted the state to expand the program. It's been expanded to 5 rural underserved communities, and all the sites have begun to see clients. Peers are playing a really important role in the rural version of this. They're acting sort of as the glue between the client services, the client and services, and we'll talk more about that when we get to some of the things that we've been observing so far. Most of the sites are defining participant engagement with Nurture Oregon as participation in any component of the program rather than all components of the program. So clients are able to choose how much or how little to engage with during intake. And multiple sites are highlighting this as a strategy to not overwhelm clients. You'll notice from the 5 that only one of them is led by a medical practice, and that we'll talk a little bit more about. So what are the aims of our evaluation? So we had really good fortune initially to be able to partner with the state to collect some initial information about startup of the sites. And we are interviewing the sites to understand those activities and the work they've been doing, as well as to understand what their experience has been so far with implementation support from the state. So that has provided us with a bridge between when this program started and when our NIH grant got funded, which was roughly in April, and quite a bit after the work had started. And one of the reasons why that bridge funding was important is because one of the most important things we're going to learn is from our qualitative data, and we didn't want to miss any of that. So our first aim is to assess the effect of the Nurture Oregon program on pregnancy, birth, neonatal, and child welfare outcomes. And we're leaning on our partners at the Center for Health Systems Effectiveness, who have a track record in creating novel databases that can link claims and vital statistics and human services data. And they're going to use these data to assess Nurture Oregon's impact on key outcomes related to maternal and infant health, as well as child welfare. And we're going to look at the differential outcomes with women with opioid, methamphetamine, and polysubstance use disorder. So essentially, to look at this aim, we're going to be looking and comparing county to county. So the work that each of these groups are doing on the ground is going to have enough impact to essentially bubble up that you can see the impact of their work at a county level. And that is the strategy that we've used, and it built on the strategy that was used in the pilot, because we didn't want to have to recruit women into the study in order to assess its effects. And frankly, the policy level findings are at the county and state level. So this was well aligned with what others would need to know, either in other counties of this state and other states, to assess the utility of Nurture Oregon. The second aim is to assess the effect of Nurture Oregon on healthcare expenditures. I can tell you that it is known that this program costs more money in the short run, and that the hope is that it will save expenditures in the long run. But we will analyze the impact of Nurture Oregon on Medicaid expenditures with a focus on implications for long-term sustainability. But the understanding from the pilot was that there would need to be investment to support Nurture Oregon care. The third aim is to describe implementation of Nurture Oregon. And the goal is to really formally describe the Nurture Oregon model so it can be replicated in other states and other settings. And here we're collecting a lot of qualitative data. So far, a lot of it has been observation of meetings and interviews with team members. But we really want to understand what the model is, how it's implemented, how it's staffed, and how the clinics and care teams are organized to deliver equitable access to care among women with different substance use profiles. And then finally, we're going to use that and the quantitative data, because each of these regions may implement a slightly different model, to understand which elements of Project Nurture are really critical, which are the difference-making elements of the model, in that they lead to improvements in outcomes. And the hope is that we can provide some specific recommendations about the way the model can be adapted for rural settings and for women with methamphetamine and polysubstance use disorders. So what's happening on the ground so far? So this is Umatilla County in the top. Umatillas program is managed by Oregon-Washington Health Network, which we call Owen. This is a consortium of organizations that include mental health and primary care, although it's a loose consortium. And they are providing counseling services, peer support, and a doula. Currently, the site does not have a designated clinician to deliver the project. Now, I'm going to refer to that clinician as an OB or an OBGYN, but I will tell you that one of the things that we are learning is that while and I may not understand this fully yet, but it seems that most of the partnerships that are being forged are with OBGYNs who deliver the babies, but family medicine doctors actually take care of the whole family. And they were pretty central to the pilot in Project Nurture. And you'll see in one of our sites where there is a family doctor, they're actually able to take care of both the mom and the kiddo once the kiddo is born. But that is not the norm in most of these sites so far. So with the exception of Oasis, most of the partnerships are being formed with an OB. And in this particular case, this site does not have a designated OB just yet for the project that's co-located. There are OBs and there is an OB located at one of two local hospitals. So they are working with the OBs at those hospitals, but each has a designated RN that's acting as their contact. And the reason why I mention this is it's going to be important later when we talk about some of what this project implementation looks like in rural communities and what some of the challenges may be that these groups are going to need to figure out how to overcome. So in addition to the standard Nurture Oregon model, Umatilla is providing a dental element, which is spearheaded by the doula and is working on setting up a home visiting nurse. Down here is Malheur County. Malheur's program is led by the health department, as Sarah pointed out, who are providing the project with peers and home visiting nurses. They are partnering with a federally qualified health center called Valley Family Healthcare, which has a women's clinic, and they're providing clinical services for pregnant people and babies at their site, as well as mental health counseling. Because of the county's location on the Oregon border, they also see clients in Idaho. And again, this is a site where the services are not located in one place. So Jackson's program is led by the Oasis Center. This is a family-centered primary care medical clinic that serves patients with substance use disorder. This clinic opened in 2019 and provides healthcare for adults and children, including medication-assisted treatment for opioid use disorder, family support services, and care coordinations for families involved with child welfare. Because of this, they started Nurture Oregon with many components already in place. They just recently added a pediatrician to the team who is supporting the family doc who leads the practice. And they are providing all of the Nurture Oregon components through this center, except SUD treatment or long-term out SUD treatment, which they're continuing to partner with treatment agencies on that. There are a couple, in their community, there are a couple of longer-term residential treatment centers that take moms and babies that they continue to partner with. This is Deschutes County, right in the middle. Their program is led by Best Care Treatment Services, a residential outpatient substance use disorder treatment program. They provide peer support, substance use disorder treatment, group and individual therapy. They have an RN care coordinator, and they are also providing optional components such as home visiting nurses. Best Care's program was built from a previous collaborative initiative concerning maternal health and substance use called the MOMS program, Mothers Outreach to Mothers, which largely focused on the therapeutic elements of Nurture Oregon. This program was established years ago and included partnerships that Deschutes County is leveraging in their expansion to the Nurture Oregon in their county. So they also have some prior experience. They are currently partnering with St. Charles Center for Women's Health for OB care. And they are loosely partnered, but not yet contracted with East Cascades Women's Group, which is the largest OB care provider in their region. So one of the ways the therapeutic organization is able to connect with women is to partner with the large OB providers in their regions. And St. Charles is one in Deschutes, the other one is East Cascades Women's Group. And they're working on developing that relationship and trust with that partner. This is Lincoln County on the West Coast. Lincoln's program is led by Reconnections Counseling, a community mental health program. They provide the peer support and the substance use treatment. Lincoln's program is uniquely prioritizing housing support and includes other optional components such as home visiting nursing and doula care. They're partnering with several organizations, Samaritan House for housing, Lincoln County Maternal Child Health for home visiting nursing, Integrity Women's Health for OB care, and the Community Doula Program. They're loosely partnered but not contracted with the local health system for OB care and pediatric care. So what are we learning so far? Sarah, this is you.
So really, integration in rural and frontier communities is proving quite challenging. I think, we're seeing multiple reasons for that. It's just the rurality, like being 4 rural and 1 frontier county, and then having existing relationships with community partners. The vision is really this integrated care where prenatal care, substance use treatment, mental health, support groups, peer support is all in one location, but in reality, that's not happening. It's not technically happening anywhere. I think Jackson is the closest, and teams are not fully integrated. I think for us, we're really trying to shift how can you integrate your communication at least, and if you can't physically be housed under the same roof. We're really seeing that there's 5 unique models rather than one model that fits a rural setting. And I think a lot of that is probably due to the fact that the funded sites are 3 different types of organizations rather than, physical health being the funded site everywhere. And 2 sites are really continuing to struggle with building their teams and developing those relationships with prenatal providers. Deb, I think you're taking it from here.
Oh no, you're up. I just tried to change the slides for you.
Oh, perfect.
This has your name on it, which is
more
maybe
challenges,
that's not right.
But no, I think that's right. More challenges that folks are experiencing and seeing is just these high levels of stigma surrounding people who use drugs in rural and frontier counties, and stigma that has really been magnified for those who are pregnant. I think this is really showing through in organizations trying to partner with other community partners and just general community level responses.
Can I jump in here,
really
Sarah?
limited. Oh, sure.
I think this is actually, I'm so sorry. I think this is actually my slide.
Okay, go ahead.
Do you want to kind of go through each of these and then I'll add? Because these look like my notes.
Fill in, sure.
Yeah.
Well, I think the limited peers and peer capacity has been really highlighted over and over. Peers are such a vital role in this program and often are really the connector between the various organizations that are partnering to be under the Nurture Oregon roof. And I think both because of, workforce challenges and just shortages, and because folks are overworked, that's just proving to be a consistent challenge across all of the sites. In addition to workforce challenges, staff turnover has been really high, and then being able to fill those positions has been really challenging. The turnover itself is really debilitating for forward momentum of sites. I think almost all the sites have lost a key player within the team within the first year, and that it does just kind of put things on pause and really makes us kind of reevaluate and think about how to structure the program. So it's a fun challenge. And of course, COVID is challenging in most ways. I think for the implementation team, it's really challenging to have to do all of this via Zoom. And communication within and across teams, especially since they're not under one roof, has been largely virtual, which is, as we know, not as effective or efficient. And then just general engagement virtually is really challenging, both within the sites themselves of getting everyone on the phone or on Zoom at the same time, and in our cross-site meetings and trainings. And especially for the site that has within the health department, there is a reallocation of staff time to be focused more on COVID. That's been changing a little bit now that things are slightly calmed down with COVID, but I think consistently folks have to kind of reassess staff allocation time.
Yeah, so I apologize for the clunkiness of this. I'm not sure how this got by me, but let me comment on some of those things based on what we're actually learning from the observations and interviews that we've done. And everything Sarah said is correct, but there's a couple of things that we've been thinking about as we've been analyzing these data that I wanted to just put on your collective radar. So, because things are interdependent. The stigma. There absolutely is a high level of stigma, particularly in rural and frontier areas when it comes to caring for individuals who have substance use disorder in general, and even more so those who are pregnant. And the idea of bringing together an interdisciplinary team to build trust and relationships was at the core of what helped the team reduce stigma and sustain themselves. And while it is perhaps what is going to be the normal manifestation of what this model looks like in rural regions where there isn't that kind of tight co-located team, we have yet to see these teams build the kind of relationships that would destigmatize to care and sustain themselves. So part of what we're hearing in interviews is struggling on building those relationships with trust with OB partners who, have a history of not necessarily wanting to get involved in delivering, and babies that have been born to moms who have substance use disorder. The stigma here is interesting because it turns out that alcohol has a much bigger impact on babies in utero than opioid use and some of the other drugs that these moms are using. But in fact, the stigma around the other drugs makes providers want to get less involved. So part of the reason for building those relationships with partners, medical partners, and between medical partners and therapeutic partners is that they can support each other and they can actually together work to create a destigmatized environment. And we do, I think, see that in Jackson at this point. And the others are just still trying to develop those relationships. That has actually quite a bit to do with staff turnover. There's staff turnover that's manifesting here that is not related to COVID, in my opinion. So if you think about your practice, whether you're, and you guys can talk about this maybe once we're done, whether you're a medical doctor or you're a therapist, your normal practice, and I can speak more easily for a physician, would include a whole range of patients, some of which you might come in for an ear infection or an upset tummy. The therapeutic analogy would be somebody that's coming in for depression or maybe mild anxiety, and that your day would be mixed with more straightforward patients and more complicated patients. What's happening with the folks that are working on the Nurture Oregon teams is that their day is all the complex patients, and that is causing a lot of burnout and a lot of tears, honestly, not to put a fine point on it. We've done some interviews where there is a lot of crying and people who say they're going to stick it out for a little while, but not that long. And that probably isn't that unusual for the startup phase of a program like this, but it is something that teams are going to need to figure out how to address. I've not heard anyone that's on the therapeutic side say that they are engaged in therapy themselves, which is probably something that they need to consider. Maybe they are and they're just not mentioning it. And it is harder because of COVID and because these folks aren't co-located to actually get a pulse from the rest of the team to know how everyone's doing. It's harder to check in with each other. And again, the lack of co-location contributes to that. I share all of this as challenges, not to be all doom and gloom, but I actually think this was what normal startup and implementation looks like. And the real challenge for the leaders in these regions is to figure out how to overcome some of this. Now, one of the things that they're doing is leaning extremely heavily on peers. And this is also an area that early findings would suggest is really interesting. So peers, I mentioned earlier, are the glue, but when you've got a team that is delivering care in 5 different locations, a lot of these teams are relying on the peers to get the patients to each of their appointments in those locations. And that is keeping the peers on the road an awful lot. There's some pluses and minuses to that. But that is making all the glue really be one person. And I guess my thinking is probably we need to expand the glue to be having sustainable teams. It's just an early thought. The other thing that's really interesting about peers is they bring a lot in terms of being of the community of patients that these sites hope to bring into their programs. And that turns out in some places to actually be very tricky when the health system may be looking for a certain level of professionalism from a peer that can make retaining those people very difficult. And we've had some attrition, and there probably needs to be enough organizational capacity for some of the leaders in these sites to be able to coach peers so that they don't reduce their value as peers and their ability to connect with patients, but they're also able to help them develop some professional skills that allow them to interface with the healthcare partners that they need to work with. So a long way of saying there's a lot of really interesting territory here that I think these sites are going to be working through over the next couple of years. So some questions that have come to our mind as we've been working through this is, do teams need more implementation support than technical assistance is able to offer? I mentioned earlier that I mean, my personal experience is they probably do. There's a lot going on here that need to be worked through. Do teams need more time to do this work so it can be sustained and than is currently available? I think they might. They're getting a really good start, but one of the things that we've learned from Jackson County is a lot of what we're seeing in the earlier sites are things that they went through a couple years ago as they sort of through trial and error put their team together. Sometimes folks didn't work out and they had to rehire for a position. So that kind of turnover that we're seeing in some of the earlier sites may in fact be normal. And it takes time to build relationships and build trust with the wide range of community partners that these organizations need to have trusting relationships with. And then another question is, when is the right time to involve CCOs? And can their influence be leveraged to be helpful? And really, what is the responsibility of the CCOs? Which we can talk more about if you're interested in terms of what CCOs are and how they might be critical in this. And I hope that gives us plenty of time for questions and discussion. Sarah, you may have some things that you want to add to what I've shared too. I want to make sure you have an opportunity to do that.
I think I'm okay. I'm very curious to hear questions from the audience, and I'd love to have a discussion.
I'm going to escape so I can see it in chat if there is, and stop sharing.
Awesome, thank you both so much. And yeah, if you have questions, I think that you can raise your hand and we can unmute you, or you can drop them in the Q&A box. Either way works. I guess I'll start too. I'm curious. There's the Measure 110 funding that there's applications due, and I'm really curious if there's any of these groups who are thinking about accessing that funding, especially to expand like some of the peer support services if those are limited, or like what those conversations look like, because they're sort of already doing what people are being asked to do with these applications.
Yeah, most of the sites are either spearheading or involved with the organizations who are applying to be the BERNs, the Behavioral Health Resource Networks. And we've tried to kind of allow for space for folks to coordinate across sites to really have uniform language around what Nurture Oregon is providing across all 5 sites. Fingers crossed they all get funded. That's been kind of one of the creative ways that we're thinking about, like, how can we expand the pilot time? Because 2 years just flies by, especially in COVID times.
Yeah, I have to say that I'm on one hand so glad that the sites are doing that. And on the other hand, just as a human that lives in Oregon, I find it extremely frustrating that these sites have to weave together support for programs and have to write grants for that. So for what it's worth, it's just a frustration. That's not how we should be funding this vital care that people need to thrive and be healthy.
Absolutely. I also wonder, as a follow-up to that question related to 110 and the funding that's going to come out, like, does it present any challenges related to the evaluation? Because it's going to expand certain services. I don't imagine that there'll be, my guess is that there's not going to be a ton of services that are funded specific for pregnant people, but there could be. But yeah, I'm just curious about any impressions related to that.
I'm not too worried about it. One of the strengths of our evaluation design is that a large effort is being put into following along what's happening with the state using qualitative methods. So if there is some sort of expansion, we should know about it. And if this were a study that just focused on the outcomes, which is sometimes the case in NIH studies, those researchers would have no idea necessarily of what's happening on the ground. So I feel like we've at least got an advantage to know what the impact is, and then to be able to weave that into what we learn. I will say that, I think I'll leave it there. We'll see how much it expands what they do and how many of these sites get funding.
Thank you. Are there any other questions from the audience, or Ashley or Leslie?
You're on mute, Leslie.
How about now? Great.
Good.
I switched from phone to workstation and hadn't fixed the microphone. Anyway, I'll just start by saying every time I hear you all talk about this project, it's so incredible. And, just want to start off by saying thank you for telling this group about the work you're doing and the service you're doing for the state of Oregon and the rural areas in particular. So really remarkable, comprehensive work. One thing was thinking about, I think it was when you were talking a little bit about AIM 2, is just the challenge of advocating for and doing work that is essentially prevention work, and then how to translate that into the cost benefits. And it does seem like the Medicaid, I think you mentioned you were going to use Medicaid, Medicare, or billing as one indicator, which is useful. And there's not really an answer to this. This is just more a reflection and maybe to hear your thoughts on it. But like because clearly the long-term impacts are not even, 1 or 2 years out, but they're 5, 10, 20 years out, when the women who are now pregnant are having children who are then teenagers and young adults, and stopping the intergenerational cycle. So it's frustrating us people who are prevention oriented to see the challenges in advocating at the state and federal level for things that it can really take a long time to show the impact financially and in terms of well-being and outcomes of the work. And just, wondering your thoughts on that, if you have any solutions, both either in terms of measurement ideas and or advocacy or messaging to key stakeholders.
Yeah, I hear you. Let me see if I can work through this a little bit. So when I initially got involved in this, it was through a conversation with Helen Belanca, who was behind the pilot in Nurture Oregon at HealthShare at the time. And she really strikes me, I hope she's not unique, because we need somebody like her at every one of the CCOs. The CCOs, in my estimation, are now a middle organization between OHA, who is essentially the recipient of federal dollars to pay for Medicare and Medicaid. And that for Medicaid now goes to the CCOs. And they have some responsibility for paying for care for the people in their geographic regions. And HealthShare, Helen in particular, was able to articulate the need for this investment and understood that it was going to cost money, that the down the road benefits of this were never going to get returned to the CCO. They were going to get returned to the community, right? It's not like treating someone for diabetes, where if you get the diabetes under control, they're not going to get their leg cut off. That's not necessarily how quickly this money is going to come back to a CCO. It's a much longer term investment. So hopefully the other CCOs and other organizations that are payers will come to have such an enlightened view, or be forced to have an enlightened view. We'll see how that rolls out. In terms of studying this, that is really challenging too, because none of the, there are no studies that have a long enough tail to actually look at the longer term effects. I think we're thinking about tackling that in a couple of ways. One is we may be able to look at some of the initial Portland sites with this grant to actually see what's going on in those now, to get a little bit of a feel for what the longer term impact is. The other thing I'm thinking we're going to probably have to do is take this as far as we can, Leslie, and then use simulation modeling techniques. I mean, they're not the same, but you can actually use the literature to think through what would be the eventual savings and to whom, based on the number of kids that are kept out of the foster care system. Those kinds of things to think about, well, what would the longer term impact of this be, given that nobody's ever funded a 20-year NIH grant for this kind of thing. It's just a weird set of values that we have when it comes to this, when it comes to research. I know our program officer was really excited to see a longer path for this research. So it could be that if there's another grant that follows on this one or subsequent ones, that in each of those successive ones, we could start to build in a investigation of the prior sites, if that makes sense, to get a sense of what the longer term impact looks like. But this is an age-old problem, and both in terms of the states not wanting to invest in this kind of care, and also in trying to establish the evidence for its, not just its value, but its financial impact. And I just sometimes think we set the bar wrong on this. You know, it's not that it costs less, it's that we're doing the right thing to help people. But we don't live in Debbie's world, unfortunately.
Thank you. That was, yeah, a really, really thoughtful answer. I like the idea of the predictive modeling. And I think the other thing I'm remembering that you touched on is, yeah, when you have one body paying for services, but the benefits are returned elsewhere, it's hard for the person who's paying to invest when they don't get the financial benefit directly. So great that you have that right current partnership.
Yeah.
I'm happy to keep asking questions. And I may have missed this, but so I apologize if I did, but are you working in any of the rural areas with folks who are not native English speakers, or is the model able to accommodate that at this stage? And maybe that's a future direction, because it's not, can only do so much at one time.
Yeah. So my understanding is that when these sites were selected, they were selected in part because the communities were intentionally serving diverse patients. And particularly Malheur County has a very large population of Spanish-speaking people that live in that county. I'm not sure that and I believe that there is the capacity in Malheur to serve Spanish-speaking patients, but I'm not quite as sure of that as you may be, Sarah. But that was the intent.
Yeah, I think they, yes, they have folks who could provide those services, but I think the designation of staffing is always kind of a struggle in Malheur, but they definitely have the ability. Umatilla as well has multiple Spanish-speaking peers. And Jackson, I believe their clinicians are, but thus far it has not been a large amount of non-white participants.
Yeah, which is going to be an interesting, very interesting. I mean, we designed our study to interview Spanish-speaking patients that participate in the program. So if there are any, we will hopefully ask them to participate. If there are none, that will be a very interesting set of findings, I think.
Yeah, I think, with some of the staff turnover, a lot of sites are looking to hire folks who are bilingual, so they have that ability. So hopefully that will expand the pool.
Yeah. Thanks.
Are there any other questions? Or final comments from Deb or Sarah?
Thanks for having us. And I mean, as you can see, we're still in sort of a messy stage of this work, which is kind of a fun and exciting place to be, but it'll be interesting to follow along and see where things settle out in the counties.
Yeah, it's such an exciting project.
And a lot of work. That was the other thing I was reflecting on, like, wow, these are full-time jobs for you
all around. Yeah, I mean, I think about that too a lot, Leslie. Like, could you imagine if you were in one of these sites trying to build this kind of a team?
Yeah.
Holy cow.
Yeah.
Yeah, I appreciated you all reflecting on the challenge, the successes and challenges too, because there are challenges.
Yeah, I mean, at multiple levels, like operational and interpersonal, and holy cow. Yeah, I think about that all the time. I don't know if you do, Sarah.
Oh, yeah.
Yeah.
I also think about just like how to implement things in small towns, because I'm from a small town, and knowing all the interpersonal and organizational drama, even in the small town I grew up, I'm like, of course, this is why it's extra challenging. Everyone knows everyone and everyone's history. So.
Yeah, that should be an asset, unfortunately, but it isn't always.
Yeah, that's true.
Yeah.
Did you pick the you might have said this, the four rural sites?
Four rural, one frontier.
Yeah. Did you select them a priori, like on purpose? Like, okay, let's go to the different corners of the state, or was it more kind of where you had the good partnerships and that also fit?
We didn't select them.
Yeah, Oregon Health Authority selected them, and it was based on existing relationships with the organization, the funded site. But I don't actually know the logic that went into, I don't think it was Four Corners.
Yeah, I'm not sure either. I mean, I think there was some combination of wanting to use this program to really serve counties that needed it and communities that needed it. And I do think that there needed to be some evidence that the organizations could pull together the resources to implement the program. But beyond that, I think the main driving force was rural, underserved, and where there was some evidence that these were communities where there were larger populations of underserved people who were living with substance use disorders. So it's not like the state picked the easiest.
Right.
They picked the hardest counties to work in.
Sure.
Yeah.
Well, thank you both so much for being here and sharing about the study. If people have additional questions, feel free to email me and I can pass them along. I'll drop my email here in the chat. And yeah, I hope everybody has a good day. And this will be, this recording will be posted unless Deb or Sarah, you have any objections. You don't need to tell me now, but you can tell me later on our website. Yeah, thanks everybody for coming today.
Thank you.
Thanks for having us.
Thank you.